Again, good evening again. This is the recording again. I tried it before and it didn't work, so I'm going to do it again for chapter 3. Uh, and it talks about the neurobiology and therapy. Um, regarding to mental health. So this is chapter 3. We kind of started off last week in class. We kind of talked about the case study with Eleanor, which was a political science professor. She came to the community clinic complaining of lack of sleep. So she speaks slowly, hesitating to think before she answered questions. And her partner Doreen was brought her in. She was worried about her. So Eleanor kind of smiled at Doreen. She just said, "I just want something for sleep. I'll be okay." So again, we need to look at what's causing her to not be able to sleep. So we kind of looked at different function of activity of the brain. I kind of focus on the function and activity of the brain. The brain is responsible for maintaining hemostasis, also regulating the autonomic nervous system, also control of our biological responses and behaviors. It also responds for our sleep, cycle of sleep and wakefulness. The circadian rhythm also, which is it's a fluctuation of physiological and behavior patterns over a 24-hour period. This is where there are changes in the sleep, so the client's body temperature, secretion of hormones, such as your corticals and secretion of your neurotransmitter. So that's what the circadian rhythm kind of addresses. And also it influences norepinephrine, that's some of the transmitters that we talk about, and serotonin. They are also influenced by this rhythm as well. The brain is responsible for memory and also social skills as well. Um, Again, the cellular composition of the brain, you have your neurons, which responds to stimuli. It conducts electrical impulses, and also it releases neurotransmitters. And as we look at the cellular composition, again, the neurotransmitters, again, it's a chemical substance that function as a neuromessengers. Those transmitters are released. They process the synapses and we're attached to your receptors in the brain. However, but again, whenever there is those neurotransmitters are reused or destroyed, enzyme D, you're going to have a deficit in your neurotransmitters and also deficit in the activity of the brain. As you can see, the function of the brain and the hypothalamus, which controls the core, it regulates internal organs and vital organs. Hypothalamus helps with thoughts and emotions and function of the internal organ. And then your brain stem is the processing center for sensory information. And again, I kind of looked at different function of the brain again, the cerebellum. Also, it regulates your skeletal muscles, maintains equilibrium. And your cerebrum, also you see that your mental activities are regulated there. We're conscious of being, emotional status, memory. All this is the function of the cerebellum. So when we're looking at mental health, we want to look at the cerebellum. The cerebellum, I'm sorry, the cerebellum, not the cerebellum. So the real cerebellum is more controlling your mental status, like activities, communication, and language. And also it helps control skeletal muscles and movement as well. So again, as we look at Eleanor, you do your assessment, going through the interview process. She demonstrates more slowness, difficulty answering questions. Doreen takes her hand and explains that Eleanor has been having more difficulty with memory lately, both in the small things like she forgot whether or not she ate lunch. Bigger things like where she was in the middle of discussing during the classroom lecture. So again, so here we see the part of the brain here that's being impacted is which one? We just said that. It's going to be your cerebrum. Again, it's responsible for her difficulty with lectures, her memory. So again, it's B here. Also, when we look at, again, like I said, different diagnostic techniques when we visualize in the brain, you have your EEG, your CT scan, your MRI. You have your functional magnetic resonance imaging. You also had your PET scan, PET emission tomography, and then your SPECT scan as well. So these are all looking at images of the brain. As you want to look at the table on page 46 in your book, it kind of breaks it down with the EEG, the description of, and what it's used for, and then in psychiatric prevalence or preliminary finding, it helps support a variety of brain abnormalities, things like Alzheimer's and things of that sort. So it looks at different levels. So again, like I said, this your structural images look at a more overall of the brain and lay of the brain. Then your functional use look at the physiological activity in the brain. So again, we'll talk about different tests as well, diagnostic tests. We'll integrate those into the diseases or the diagnosis. So with that being said, which neuroimaging technique will reveal the problem of the anatomical structure of the brain, but not problem in the function of the brain? And again, it's going to be your CT scan. CT scan look at the structural images, and the MRI will give you more of a visual images of the brain and the layers of the brain. So when we look at structures, we want to use a CT scan for that. As far as disturbance in mental health, it could be genetic again. It could be due to an imbalance of your neurotransmitters, your norepinephrine, serotonin, dopamine, glutamate, GABA, neuropeptides, and acetylcholine. So again, when there's an alteration in any of these, um, again, there's a basis of psychiatric disorders. And then again, it leads us to what pharmacological treatment we want to use for these clients based on these disturbance of the mental of your neurotransmitters. And then again, like I said, also genetic. It kind of helps us determine what medication we're going to use for these clients. The medication, again, as far as action of psychotropic medication, what they do, what they don't do, the actions. Again, I went over the drug sheet, the little psychiatric medicine that most commonly used. I kind of highlighted some. So you have medicine that acts as an agonist, which mimics the effects of neurotransmitters naturally found in the human brain. So meaning that if there's a deficit in your serotonin and dopamine, you want to give a drug classification on the agonist because it mimics that of that transmitter. And then antagonist, it blocks the neurotransmitter from binding to the receptor. It obstructs the neurotransmitter action. So again, if you got too much serotonin or dopamine, you want to give them an anti-agonist. When you don't have enough, you want to give them an agonist. Okay, so that's the difference. As far as anxiety and hypnotic medication, we kind of looked at some benzodiazepine. And I told the class again, we kind of talked about looking at those drugs that ended in PAM. These are benzodiazepines that are used for anxiety or panic attacks. So again, they promote GABA by binding to that specific site on the GABA. It helps to increase frequency, opening those membrane, which causes cellular excitation. So benzodiazepines, in essence, they possess anti-anxiety. So if you're having an anxiety attack, you want to give them something, an anti-anxiety medication. Also, you may use a hypnotic for those clients. Also, those clients with, you may also use an anticonvulsant. Um, Amnesia, loss of memory. You want to give them a benzodiazepine, and also it can be used as a muscle relaxant. So again, on the handout, like I said, I think it's on page 13. We were looking at those benzodiazepines. Let me try to get to that real quickly here on my sheet. Make sure I got it right. A second. I need to, what I'll do the next time I'll upload these, I put numbers on there. So again, like I said, it's on page, the last page of anti-anxiety medication talks about benzodiazepine derivative. Some effects of that could be lethargy, could cause respiratory depression, So again, also nurse consideration could be a central nervous system depressant. So if it depresses the central nervous system, again, these clients could have some drowsiness effect of that, so they can't operate machineries. So diazepam is one of the ones that are used most frequently. Fluorodoxapine, dioxypyde, Spazide, I'm sorry. It's another one, but diazepam, the ones that ended in Pam are the most frequent ones. So you see those diazepam, clonazepam, olazepam, I'm sorry, clonazepam, and then lorazepam. These are some of your commonly used benzodiazepine. Again, like I said, they can cause drowsiness, hangover, and also respiratory depression. So with that being said, there's a safety issue. We did monitor the client respiratory status. These are some more also drugs that are used to treat insomnia. Um, Tasmapam, also trizolam. So again, those drugs are in and Pam and Lam are going to be your benzodiazepines again. Chlorodiazepam oxide, same thing as Librium. It's another one. Also commonly used, and then of course Ativan. So we know these drugs can cause some central nervous system depressant respiratory system, and also drowsiness and lethargy. So these clients need to be taught. They can't operate machineries again. Then you have some short-acting sedatives, and these your non-benzodiazepine. They're short-acting. They're used for short-term only for the most part because they're very addictive. So again, so there's been a warning on these medication regarding complex sleep-related behaviors. So again, these are called your Z hypnotics. Melatonin agonists. Again, like I said, there's a deficit there. So the agonists, we want to use those Remeron, rosmarin. I'm sorry. Rameltion, I'm sorry, I can't talk this evening. Rosmarin is a melatonin agonist. It can be used to help with sleep. Um, Buspirone or Buspar, it also is an agonist that can be used to help with sleep. These are some of the common. Then you have your MAOs or monoamines. Again, on your sheet, we looked at MAIOs. They're used to treat depression, and we talked about the side effects of these MAIOs. Hypertensive crisis was a big one, so I encourage you to look at your handout there, looking at the nursing consideration, and then again, like I said, the adverse effects of these medications. Orthostatic hypertension was one of the big ones there also, and hypertensive crisis. So again, you're giving a client an antidepressant from this derivative, you want to make sure you teach and know the signs and symptoms of hypertensive crises, and it's because you need to know what to teach the client. And so, with that being said, I'm gonna give you an example that's of one that's commonly used on your first page. Phenazine sulfate. It is a MAO inhibitor, and you see the adverse effects there is hypertensive crisis when it's taken with those foods that are high in triamine. And salami, you see that on the list: eggs, cheese, red wine, bananas. Again, over-the-counter medication are contraindicated as well. Photosensitivity, if they're going to go outside, they need to put on long sleeves. Weight gain is one of the effects, and then sexual dysfunction. We need to teach the clients these because they need to know what to expect. And then again, orthostatic hypotension. Okay, so again, look at on that sheet. You're going to look at your antidepressant, buspirone, trazodone is one on that heterocyclate, and then your MAIOs, phencyline, like I said, phenazine. It's been used. It's one of the commonly used ones. on the market for the most part. Not to say that they won't, all else won't be used, but I'm just giving you some that is highly used that you see. Uh, okay, as far as classification of drugs, again, if you go back to that sheet, you're gonna look at your antidepressants, the SSRIs, NSR, your non-epinephrine serotonin, and then go on down the list. But we're gonna break those down. I kind of went over a few. So again, antidepressant medication, MAROs. Also, you have your serotonin uptake SSRIs, fluoxetine and paroxetine, so sertraline, some of the commonly used one that you would see also, your SSRIs. And then again, look at some of the side effects, adverse effects, and be able to teach the client. So rash is commonly, you see that with your SSRIs, you're an upper respiratory infection, weight gain again. With these SSRIs, you're going to monitor for thrombocytopenia, which clients going to be at high risk for bleeding, and also leukopenia and high risk for infection. So you need to teach the client those some of the side effects under your SSRIs. Mood stabilizers. We talked about lithium. We talked about that a lot. Lithium again. It's a mood stabilizer that we use a lot. However, there is some cautionary measures with lithium. Depakote, valproate, or Depakine is some of the commonly used mood stabilizers. Carbamazepine, another one. Lamotrigine is another one that's commonly used. Also, let's kind of go back to our sheet on lithium. And I kind of highlighted some stuff on lithium. Make sure the client drink a lot of water because they become sodium deprived. I mean, they need to drink a lot of water because the sodium level will elevate. So we need to give them a lot of water, at least 2,500 to 3,000 milliliters a day, unless it's contraindicated. Now we know there are clients that in congestive heart failure, renal failure, we have to use our nursing judgments to know that they can't tolerate that much medication. However, we need to, the lithium, there's some signs and symptoms, lithium toxicity that I've outlined that we need to teach the client that they need to monitor for. And again, like I said too, with this mood stabilizer, there's a therapeutic range, meaning that they need to get their lithium level checked. Um, it, at least monthly or frequently, however, whenever the order, the prescribed order, but it needs to be for the nurse consideration for lithium is used for manic depressive disorders. Blood levels must be drawn frequently. We want to give this medicine with food to help decrease the GI upset. And if a client been taking that medicines for 5 days, we need to let them know it takes 1 to 2 weeks for therapeutic effect. And then I mentioned also lithium toxicity, where the lithium level is elevated, and you're going to look for things like vomiting, diarrhea, drowsiness, ataxia, muscle weakness. These are some signs of lithium toxicity. Again, they can have what we call reversible leukocytosis. Again, monitoring their blood levels for white blood cell count. So again, lithium is a mood stabilizer that you need to hone in on. And we'll talk more about carbamazepine later on. But lithium is definitely, you need to look at that. Okay. Also, let's see here. As far as your antipsychotic medication, you have first generation, second generation. You also have strong antagonists, which is a blocking agent. We said it's too much, so we want to give them something to block the transmitter. So it blocks the dopamine. It reduces the dopaminergic transmission. So the first generation drugs that we use for as far as an antagonist are going to be your acetylcholine, your norepinephrine, your histamine. And some of the side effects of those you can see: weight gain and sedation. So if they're going to cause weight gain, we need to teach the client. They're going to cause sedation, we need to put in some safety measures, intervention. Also, your second generation antipsychotic, they have fewer extrapyramidal side effects. And these second generation target negative and positive symptoms for the most part. So with that being said, so basically the two neurotransmitters that they are targeting going to be your dopamine and your serotonin. Okay, so often, since they have fewer side effects, your second generation have fewer side effects, so they're often going to be your first line of treatment because of the fewer side effects. So remember that. Your second generation is going to be your first line because of the fewer side effects for those clients with and again, this is what I was talking about here on the next slide. As we look at the second generation, they have fewer side effects, but there are some things that we need to look for. Like I said, your clozapine, your olanzapine could cause a decrease in your white blood cell count. So these clients are going to be at risk for infection. So we need to talk about that. Zuprazidone is another drug that maybe you may commonly see. Quetiapine, maybe another one. Risperidone, again, like I said, they block. Okay. These are some other second generation drugs that you may see. Also, these are some medication you may see for ADHD, which ADHD is going to be a different, going to be a diagnosis or disorder we're going to speak um, specifically about. And as we talk about ADHD, we'll talk more um, about the drugs. So we'll pull those in. But methylhydronate, you may see that that's the same thing. It's been out on the market for quite some time. So this may be one of your first line drugs here. And then also your amphetamines, Adderall. Sometimes people use that for attention deficit to help with weight loss. I'm sorry, but there are some side effects. Okay. Um, with that being said, these medications, due to their norepinephrine and dopamine effects, because you could see some insomnia, increase in blood pressure and heart rate. Like I said, that may be some of the side effects of that. As far as medication for Alzheimer's, again, Alzheimer's medication is going to be used to slow down the destruction of acetylcholine. Cholinesterase inhibitors. Again, it slows down the destruction of acetylcholine. When the acetylcholine is destroyed, based on the MRI, you're going to see those changes there, and it helps with define the diagnosis of Alzheimer's. Rivastigmine has been a drug that's been used. Exelon, you see that a lot. Aricept or Donepezil. Also being used. And then your glutamate blocking agent, Namenda, um, um, also is a drug that's been used quite a bit. So again, your cholinesterase inhibitors slow down the rates of memory loss. So again, they slow down the destruction of acetylcholine. Okay. And then herbal medication, again, they may have, they may show some positive effects. That's why we tell the client, if you own any over-the-counter medication, you need to bring them in because drug-drug interaction. They may lack efficacy and safety because they lack FDA approval. So again, they need to be brought into the healthcare provider, so they need to know what those medicines are because of drug-drug interaction. So your herb medicine. So again, patient with decreased circulating levels of GABA, push problems that's most likely to suggest, and again, it's going to be anxiety disorder. So neurotransmitters GABA seem to have a role in excitability and causing anxiety. So you're going to see a decrease levels associated with anxiety when you get those clients on that medication.